Sarel Gaur. So let's talk about hospital-based employment versus private practice employment. So I've done a little bit of both, and so far I've got my thoughts. Again, for me, I think being hospital employed works, and I'll tell you why. And kind of the first reason is that to me, being hospital employed, it feels more stable. It feels a lot more stable. When you're in private practice, you are in a group. You might be in a group of 10, 15, 20 people. Um, your contract of the group's contract is with the hospital, but you don't work for the hospital. In fact, the hospital really doesn't see you as being part of them. You're on staff at the hospital, but you're not really part of the hospital. When you're in hospital-based employment, it's just set up a little bit differently. Um, the group that you work for is typically fused at the hip with the hospital, and there's really a fusion there and a reliance, and kind of they really want to work together. There's really not there there could be adversarial motives, but there really tends not to be. It tends to be that the group and the hospital want to work together to get on the same page. And what that means for you is that as a physician, you tend to feel not so much that you're part of a small group, you tend to feel that you are an extension of the hospital, that you're fused with the hospital, that you are basically acting as an entity, uh, as one with the hospital system. You're an extension of the hospital system. Now, again, some of that independent thought of being a private practice physician is sort of lost, but what you gain is you've gained some stability. You have fused with this healthcare system. And that healthcare system will tend to be usually pretty financially viable. Usually in the community, it has kind of a good reputation. It's got local political power. It tends to own its own buildings, so it has assets, relative to, say, a private practice that may not have any assets. The healthcare system has assets. So when there may be a tough time, where the economy sort of crashes, the healthcare system has assets. It has something it can borrow from, whereas the private practice that has no assets, it could fail, during an economic downturn. So again, stability. In employed practice, you tend to get to practice within your subspecialty. So in IR, this is huge. There's people in IR that they don't want to do diagnostic radiology. In private practice, pretty much I was doing about 50-50. I would say most private practice doctors are doing about some version of 50-50. That might be 75-25. It's not typically 100%, but hospital employed, my contract, again, my contract is not to the group, but it's through the hospital, and it's for 100% IR. A little bit of diagnostic work like CTAs and stuff. So for me, that kind of works out. I mean, I don't mind doing diagnostic, but for me to practice 100% IR, again, that helps me grow as an interventional physician, and that's something you get with hospital employment. Now there's other issues. It's not all perfect. Am I always doing big cases? Not necessarily. They want us to do the big cases. They want us to do the small cases too. And there's politics. Private practice, politics. Again, my experience was I didn't really see politics. If there was a PAD case and it went to IR, it went to IR. If it went to vascular surgery, they did it. But sometimes they'd come to us and then we did it. And nobody was saying that IR can't do PAD or IR can't do this or IR can't do filters. Pretty much whatever came to whoever, they did it. And there's sort of kind of a bit of a free for all aspect there. Hospital employed is a little different. You really have to learn to play the game, play a little bit of political game. And, for example, a lot of different services that do dialysis work, like vascular surgery. And it might be that at that institution, they want the vascular surgeons to do the dialysis work. And you have to learn to work with that. It might be that G tubes tend to be done endoscopically, and you have to learn to work with that. Now, does that mean that you can't first of all, you can focus on other cases, you can focus on growing oncology work or anything else that you're interested in, spine work, anything really at all. But it's just something for you to know is that there's going to be some political rules, and you may not some things that you're used to. So if you're used to doing a lot of leg cases, you might get thrown into a situation. You're hospital employed, you've got stable employment, but you're no longer doing any legs, and the chance that you're going to do legs is pretty low. And again, it's something that you may have to deal with. Pay and compensation. I think there's this idea that private practice physicians make a ton of money. They're compensated really well, especially when they're this partner, when they're so-called partners within the practice, which again, it's a complex thing. It's not just one thing. But when you're a partner in a private practice, you tend to think that you're making a huge paycheck, and then it's really worth it. I think there's an idea of that. The chance that you'll see that is I'm just not sure. There's usually a path to partnership. It's usually several years, and it's not always straightforward. And unfortunately, you're not going to know a lot about the details of it when you first start out. What I see with employed positions, they're a little bit more straightforward. They kind of tell you right in the contract what you're going to make, and that's what you make. And usually you do have the ability to moonlight on the side. And I would say, again, my experience is that if you're employed, yeah, your salary might be less than a private practice partner, but if you do some moonlighting on the side during your off time, I think your income could easily hit low to mid-range private practice partner salary within your first year of hospital-based employment. So within your first year of being hospital employed, I think you could hit a private practice partner salary, and you don't have to wait the 3 years to do it. So I think that's something to think about. Again, that's something that has worked out for me, and it may or may not work out for you. The perks are less. Private practice, free coffee, free lunch, free dinner, free, whatever you want from the cafeteria. Free smart water bottles. I used to run in the cafeteria and just grab, a couple smart water bottles and just drink them and then maybe take one home. You don't really get to do that in hospital-based employment. The perks really aren't there. You do get a little bit of free food. You get some free soup for lunch, but it's just not the same. No free coffee. Other more important perks, for example, actually, one nice thing about being employed is they might have, like, say, for example, a nurse practitioner as part of your team. Whereas in private practice, that's an expense. So they look at the expenses very closely and usually nix them. But employed position, for example, you may be more likely to have a nurse practitioner that works with you, that takes care of a lot of the clinical, like just basically work that helps you see more cases, see more patients. And you're more likely, I think, to have that in the employed situation where they kind of have some leeway in the system to help you have a mid-level to help grow the practice. So, and then lastly, since this video is getting a little long, I think again, personally, in my experience in employed versus private practice, there's less of a focus on RVUs and production. Private practice, unfortunately, the sad truth about it is that it is based on RVUs, and they look very closely at RVUs. And this is why sometimes IR can be undervalued in the private practice settings, because IR procedures, believe it or not, don't always make a lot of RVUs, depending on what you're doing. But I found in employed practice, there's less of a focus on RVUs. I think there's more of a focus on providing quality care. And what that translates to me is that if I'm doing a long, complex case, rather than thinking about how much time it's taking me, I can really focus on doing it right, taking my time, investigating all the vessels, doing a nice job, talking to the patient's family afterwards, taking my time to do that, talking to the referring physicians afterwards, taking my time to do that, spending time rounding on them, which may or may not create additional RVUs. I can spend time doing that as an employed physician. Private practice, there's certainly a lot of disincentives to doing that. There's a lot of incentivization of doing the work as quickly as possible, and then not spending much time doing anything that does not generate RVUs. So, anyways, that's a lot of things there. But basically, yeah, my thoughts so far are, again, it's a tough decision, but employed versus private practice. For me, I think employed is working out, and I think for a lot of people, employed may work out, and it's something to consider relative to private practice. So, Sarel Gaur.